Picture this. You're 2 minutes into your OET speaking roleplay. You're taking a history for unexplained weight loss, and you need to check for red flag bowel changes. Suddenly, out of nowhere, you ask, "Have you noticed any blood in your stool?" The patient's eyes widen. They stammer, look terrified, and go, "Wait, blood? Why on earth are you asking me that? Do you think I have bowel cancer, doctor?" Look, we've all been there, under exam pressure. When that 5-minute clock is ticking down, your brain panics and strips away all conversational padding to save time. But dropping a heavy red flag question without context triggers instant health anxiety. Notice what happens in that exact moment. You spend the next 45 seconds de-escalating cancer panic instead of completing your history. That sudden friction is an instant double penalty across your official scorecard. You lose marks under relationship building for causing unnecessary patient distress, and your timeline collapses under providing structure. In this masterclass, we are going to fix that exact bottleneck. I'm going to reveal why unframed questions trigger automatic interlocutor pushback on test day, and give you a simple 3-step protocol to ask intrusive questions with total clinical authority. I am going to give you the exact framework to fix this in just a minute, but before we break it down, you have to understand how the interlocutor is instructed to react on test day. When a scenario involves sensitive topics or red flag symptoms, whether it's bowel habits, alcohol use, or sexual health, their prompt literally tells them, if the doctor asks intrusive or alarmist questions without pre-framing, react with panic, hesitation, or defensiveness. You might be surprised to learn that they aren't trying to be difficult. They are simply following an explicit directive on their card to test your ability to handle human delicacy and manage patient anxiety under pressure. When you fire off abrupt questions, you literally force the interlocutor to execute that panic prompt, pushing them into an emotional derailment that destroys your consultation timeline. To ask intrusive or sensitive questions naturally, without scaring the patient or losing a single second of clinical control, we deploy what I call the clinical cushion. Instead of dropping a direct question out of the blue, we cushion the transition using 3 quick elements. First, state the rationale. Explain why the information matters clinically before you ask for it. Second, use the 5-word universalizer. Pay close attention when we reach step 2 of this protocol in a moment, as I'm going to reveal a subtle 5-word phrasing shift that satisfies incorporating patient perspective instantly, without giving away a single second of your clinical runway. Third, ask for soft permission. A simple check-in preserves their autonomy and keeps them completely relaxed. Watch how Dr. B handles this exact same moment using the clinical cushion. Listen to how the tone and pacing completely shift when delivering this. To help me build a complete picture of what might be causing this fatigue, Mr. Hopkins, I need to ask a few routine questions regarding your bowel habits. We ask all our patients presenting with these symptoms these exact same questions, just to rule out anything underlying. Is it all right if we touch on that briefly? Right. Yes, of course, doctor. That's fine. Thank you. Have you noticed any recent changes in how often you go to the toilet, or any blood in your stool? Notice how opening with "to help me build a complete picture" justifies the shift, while "we ask all our patients" completely neutralizes health anxiety before it takes root. That is the exact 5-word pivot that keeps the interlocutor calm, ensuring your timeline keeps moving without a single hitch. If you're sitting there thinking, I definitely sound like Dr. A when I get nervous, don't guess where your consultation structure is leaking on test day. I built a free 60-second interactive audit that calculates your exact structural risk score based on your real practice habits. Select the exact communication liabilities you tend to drop under pressure, get your instant risk diagnostic, and unlock the complete clinical framework breakdown. Pause this video now, click the link in the description below, run your 60-second audit, And let's jump straight into how to pace this inside your 5-minute window. Inside your 5-minute consultation, sensitive inquiries live strictly between minute 1 and minute 3 during history taking, or targeted exclusion, I call it. If you cause panic at minute 2, you will spend the next 45 seconds de-escalating anxiety and reassuring the patient. That means by minute 3, you haven't even touched your management plan, resulting in a rushed, incomplete safety net at the end. Deploying the clinical cushion executes sensitive transitions in under 15 seconds, keeping your consultation perfectly on track for your final sweep at 4 minutes 30 seconds. Now, I'd love to know your personal test day friction points. Drop a comment below telling me which sensitive topic makes you freeze up the most. Is it taking a sexual history, probing alcohol consumption, or asking about red flag bowel habits? I personally read and reply to your comments to help you fine-tune your phrasing for test day. If you haven't run your diagnostic yet, hit the link in the description, take the 60-second audit, and let's secure your consultation structure. I'll see you in the next masterclass.